So obviously the title today gives you a little idea of what we'll go over, and hopefully by the end of this, you will have more confidence knowing that you probably most likely already deal with acute respiratory distress syndrome. We're going to do the Berlin criteria initially, discuss current evidence-based positive pressure ventilation recommendations, and then we're going to segue into maybe a case or two and then do a summary. So as we move through, if you have any questions at the end, there will be time for those. I have no conflicts of interest to report. All items we'll discuss just simply based upon ARDS, the scope thereof, and ARDS clinical management in general. And with that said, let's just define some learning objectives. Likely all on today's call have more than just heard of ARDS. You've probably been involved with the care of patients with ARDS for a long time, regardless of your experience level. And just like most broad-reaching topics, though, quite a lot has changed over recent years. And we'll discuss how ARDS is currently defined and classified. And we'll move into arguably the most important portion of today's topic, and that is the treatment thereof, specifically mechanical ventilation strategies. And the goal is to hopefully walk away with something you can put into use immediately in your bedside practice. The real goal of today, as always, is to do better patient care. So a worthy starting point, just a quick bit of historical perspective. The label acute respiratory distress syndrome itself implies its sudden onset and is a respiratory specific condition. The term syndrome usually refers to a recognizable complex of symptoms and physical findings which indicate a specific condition for which a direct cause is not necessarily understood. And although we do know certain insults can predispose an individual to developing ARDS, there's still no definitive stimulus or even a predictable insult that absolutely will cause the ARDS condition. There's a short list, and we'll go over that as we move along, where ARDS is more prevalent with XYZ, but we'll address this more as we progress. So the condition of ARDS was originally reported in 1967 through a publication in The Lancet by the world-famous Dr. David Ashball at The Ohio State, where a dozen patients from a case series were identified to have a particular presentation or pathology, if you will. Essentially, they all looked the same clinically, or very similar. What was most interesting, though, about the early observations of this syndrome is the presence of persistent refractory hypoxia and oftentimes non-direct involvement of the lung. So the disease process that would eventually manifest to what we consider ARDS did not necessarily have a primary origination in the lung. In other words, patients would develop this persistent and pervasive respiratory distress, whether it was a direct insult of the lung or not. And they pretty much all had some degree of pulmonary edema on chest X-ray. Without any obvious cardiovascular compromise, they were not in left ventricular failure. Most of the early case series involved younger, generally healthy servicemen. And this was, of course, the Vietnam War days, late 1960s. And so you can imagine, by the way, certain of these patients did respond to PEEP. So ARDS have many descriptions and borderline what we would call formal definitions from about the 1970s to the 80s, which, as you heard in the entry music, the 80s a pretty good decade, I would say. And even into the early 90s, there was very little agreement among key groups as to how do we define this condition. It wasn't until 1994 that ARDS was first formally singly defined by the American Respiratory Consensus Conference. And this gave way eventually to a panel of experts in 2011, and they were convened as an initiative of the European Respiratory Society and the Society of Critical Care Medicine. And they developed what has come to be known as the Berlin definition. And so this Berlin definition that we have that was established in 2011, really it was because of where they met that it got its name. So the Berlin definition quickly became the gold standard in defining ARDS. Starting from the so-called early years of defining ARDS, circa 1990s to early 2000s, the PaO2 to FiO2 ratio, being arterial partial pressure from the arterial blood gas, that value, compared to the FiO2 that they were receiving, that comparison, and then various other clinical indications of significant respiratory impairment have long been a part of the criteria to say someone officially has ARDS. But it wasn't until the European Respiratory Society of Intensive Care Medicine, with an endorsement from the American Thoracic Society and the Society of Critical Care Medicine, convened an international expert panel to revise the ARDS definition in Berlin, that again, we have this so-called Berlin definition. That's where it was born, out of a meeting that occurred in Berlin. So that's why that name carries. The Berlin definition, though, changed everything. In fact, this is one of the most cited articles in critical care medicine, hands down. And I'll say it early here that the term acute lung injury, also known as ALI, kind of has come and gone. We still talk about ventilator-induced lung injury. You still hear the term thrown around, but in the literature and in evidence-based classifications and such, the concept of ALI is still alive and well, and with good reason. But clinically, acute lung injury is certainly a feasible concept, but I'll say we're going to continue to focus solely just on ARDS today during today's webinar. That said, let's look over the original Berlin definition that changed everything. And I'm going to quote from the publication you see there on your screen. Compared with the prior circa 1994 AECC definition, the final Berlin definition had better predictive validity for mortality, and that's why it has perpetuated. So the original Berlin definition included 3 mutually exclusive categories of ARDS based on degree of hypoxemia, all of which was determined by an evaluation of the PO2 to FiO2 comparison, also known as what we say is the PF ratio. So mild would be less than 200 PF, I'm sorry, less than 300 PF ratio, but still up to 200 or down to 200, but not lower. Moderate would be in between that 100 torr range to 200 torr range for the PF ratio. And then severe would be a PF ratio less than 100. And so you can see from the provided chart, extracted from their original article, that, of course, timing, given the name, it is acute, is important. So the onset is within a week or less. Also, chest X-ray or CT, for that matter, is important. Opacities have to be present, also known as infiltrates, to say that someone has ARDS. The thoracic infiltrates must be from a non-cardiac origin. In other words, yes, heart failure can cause pulmonary edema, but that doesn't classify as ARDS. There is assumed presence of true respiratory failure. And finally, the crux of the entire classification process is the PF ratio, which you can see allows a separation into different severity categories. So to be clear, although relatively unpredictable and oftentimes a random finding, ARDS usually manifest after a significant infection or particular physical trauma. And that particular trauma does not necessarily even need to directly involve the thorax, as I mentioned just a moment ago. So shown here is one of the more popular images to depict the ARDS condition, shown far left side of the picture, the clearer version. The take-home message with ARDS pathophysiology to the right is it involves a horrendous inflammatory cascade that results in infiltrated processes, fluid accumulation in the lung, and then leaky pulmonary capillaries with this aggregation of platelets atop all the other issues that accompany a typical inflammatory response in the lung. So even though it's a very busy picture here, to the right, you notice all of these cellular elements, the debris that's labeled here, and also some of your what we call inflammatory mediators, or they're also known as chemical messengers, the cytokines that are released that stimulate other things to begin to gain attention in that area. Platelets aggregating give way to the potential for clotting, which we do not want, of course, when we already have a thickened AC membrane. Worth mentioning is some of the most common nomenclature associated with ARDS or an ARDS-like condition. Now, to be clear, these are not standardized and they're more colloquial, or just clinically, we would consider it slang in some cases. We're focused on the standard acute respiratory distress syndrome today, just known as ARDS. But before moving on, just a side note, the term baby lung is often really mentioned in and around ARDS, has nothing to do with neonates or infants, but it's called baby lung. And this description of baby lung just refers to the leftover good lung tissue when ARDS is present. So essentially you have just a smaller version per capita in sheer volume of available ventilatable or lung tissue that's available for gas exchange, is a good way to think about it. With ARDS being a syndrome and not necessarily a disease, because there really is no known specific cause, it's not black and white, there are patterns and certain indications a patient may be at risk for developing ARDS, but in the end, it is a clinical syndrome, and therefore a diagnosis would be made according to just the clinical features, what is manifesting at the time. So here's the short list. It's alveolar permeability that essentially presents the major challenge, because suddenly you have intraalveolar fluid accumulation causing a VQ mismatch and also a right to left intrapulmonary shunt. This makes for immense difficulty oxygenating these patients. They have extremely low lung compliance, and it's just a vicious cycle. If you recall, as a ventilator manager, as a respiratory therapist, as an expert in pulmonary medicine, the more stiff the lung, the less compliant the lung, the more creativity it takes to ventilate. Otherwise, the cycle of alveolar infiltration continues. We're trying to avoid cyclic opening and closing of lung tissue, and we certainly want to avoid overdistension. Maybe ARDS can be summarized simply as sudden respiratory failure unrelated to heart failure, or specific fluid overload unrelated to fluid overload in the lung, particularly unrelated to the typical mass edema that we see with other diseases. So back to our earlier picture, we certainly know that the ARDS pathophysiology is complex. And given its namesake, it affects the lungs initially. That's when it first is maybe noted in the realm of our clinical management. But there is a multi-organ risk involved. In fact, a major portion of the mortality associated with ARDS is related to multiple organ dysfunction syndrome, also known as MODS. But that's a topic for another day. So before we move on, focus in on not only the alveolar involvement to the right side of the picture, but the intravascular and extravascular activities that are ongoing. Notice all the inflammatory mediators, such as interleukin, that are pervasive both in the alveoli itself and within the capillary. Also, because of increased capillary permeability, there's a massive fluid shift from inside the capillary, inside the vessel itself, more toward the interstitial space and even into the gas exchange unit. These patients are very difficult to oxygenate. Does this sound familiar to something else we've encountered en masse over the last 2 to 3, 4 years, COVID-19? And it can be difficult to look at a chest x-ray, to look at the pathophysiology at the surface, and to look at vital signs and such, and say that it's ARDS and not COVID, or vice versa. Of course, when COVID is positive, found positive, you can definitely say there's a cause, but ARDS is a little bit different. So as with the discussion of any disease or disorder or syndrome even, it helps to quickly outline the epidemiology. And a really well-done article presented just a few years ago in the American Journal of Respiratory and Critical Care Medicine is shown here. It reviewed 50 years worth of research and publications on the topic of ARDS. And what's mildly disturbing is the Canadian group of researchers admit that despite their bold statement that no other intensive care syndrome has been as extensively studied as ARDS, we still have many basic epidemiologic questions that remain unsolved. In other words, this syndrome's incidence, distribution, the ways to control it, and just overall relative factors are not easily identified. And we're talking about approaching closer to 70 years of research coming up, 60, 70 years of research here, if you count maybe some that were not as prominent in the literature in more historical times. So the group here, they cite the lack of standardization and exact onset of ARDS is not always easy to identify, even though our understanding of ARDS pathophysiology has certainly improved over the 5+ decades of published data. Remember, there were publications prior to naming the condition, the syndrome, that may have been alluding to ARDS, but there really wasn't that nomenclature at the time. So here's what we know. Not necessarily pharmacologic intervention, although yes, corticosteroids and diuretics have their place, but it's the avoidance of ventilator-induced lung injury that should be the target of ARDS management. Protective, protective, protective. And yes, we have a lot to consider, which we will get to shortly, including non-invasive ventilation, high-flow nasal cannula and ECMO, and even extracorporeal CO2 removal, which we do at my local facility here, could be thrown into the mix as potential options for treatment. Not that ARDS is a CO2 driven issue as much as it is an oxygenation issue. So just backing up a bit here, I'd be remiss if we didn't at least quickly discuss the famous LungSafe study. Well, LungSafe standing for Large Observational Study to understand the global impact of severe acute respiratory failure. That was a very creative acronym they came up with. You'll notice some very famous names on this research team. This group completed an international, multi-center, prospective cohort study of patients that were undergoing invasive or non-invasive ventilation. So it was a large group. They conducted this study during 4 consecutive weeks in the winter of 2014. So we're talking roughly 10 years ago. And yes, it was a convenient sample for you that are more research inclined on the call today, but they studied patients among 459 ICUs from 50 countries across 5 continents. That's a lot. That's a lot of subjects. They ended up with just over 29,000 ICU admit patients. And of these, just over 10% fulfilled ARDS criteria. So a gross summary of that would be that roughly 10% of patients that receive mechanical ventilation in an ICU are expected to probably display ARDS. Not surprisingly, we're just not good at recognizing ARDS. We're not great at treating it. And unfortunately, yes, ARDS is associated with high mortality rate. All of this is a very good reason we're on this webinar today, right? So things changed forever circa about 2020, and I'm not telling you something you do not know, but when COVID-19 began its reign of terror, we instantly had all of these patients that, at least on chest x-ray and ventilator management wise, had an ARDS-like presentation. What we know now is that it's really not possible to separate ARDS from COVID-19 within the scope of how chest x-rays and various labs and even overall clinical presentation, pulmonary-wise, would manifest. Arguably, severe cases of COVID-19 are more difficult to treat and require more creative approaches to both ventilator and overall clinical management, but nevertheless, ARDS criteria is ARDS criteria. So there are over 60 known etiologies of ARDS, but here is just a short list of some of the most common precursors to the development of the syndrome. And if you've worked in a hospital setting for almost any amount of time, you no doubt have seen most of these. If you work at a trauma center, you'll likely will see ARDS more than the average clinician. But ARDS can develop at almost any time in almost any patient. We're talking young or old. The official diagnosis, however, is not always clear-cut. You can see in the second column labeled clinical features that there is certainly a high variety and almost no definitive diagnostic test exists for ARDS. The chest X-ray, as a reminder, is a key feature in the overall assessment of ARDS. Recall that fluid specifically infiltrates the alveoli without an indication of cardiac failure of typical fluid overload. ARDS is a pulmonary condition. To reiterate, you have patients that have a pulmonary edema presentation, but they are not considered fluid overloaded, and they are not considered with direct cardiovascular compromise necessarily, especially early on in what we know as the exudative stage, which gives me a segue into our next slide here. As with any lung condition, there is typically that early or acute phase, there's the more chronic phase, and then of course recovery, or what we might consider, some would call the convalescent or the dormancy stage, depending on the disease or the process. With ARDS, though, it's all an acute process, right? I mean, it's in the name. Well, although ARDS, given its namesake, is a rapid onset and a relatively unpredictable syndrome, I mean, it's literally acute syndrome, there are so-called stages to this syndrome. The early exudative stage, also known as DAD, standing for diffuse alveolar damage, it occurs within the first 10 days of the process. And yes, it's not dissimilar to various other acute lung conditions, but ARDS can also be a prolonged recovery process. The histological hallmark of this early exudative stage is what is known as diffuse alveolar damage. We're actually damaging the lung exchange unit. Think edema, think cellular infiltration, and these inflammatory cells, they migrate to the site of gas exchange. And if you recall from way back in RT school, when you thicken that AC membrane, what you're doing is essentially creating an increased barrier to oxygenation. The next stage beyond the first 10 days is known as the fibroproliferative stage, in which pulmonary edema actually resolves, but cellular infiltration and multiplication continues. So we're still not out of the woods. Essentially, the lung fluid is decreased during this fibroproliferative stage, but the cellular debris continues to accumulate. So you have layering of all of this matter and cellular debris, preventing, again, adequate gas exchange, particularly oxygenation. The latter stage of ARDS, known here as the fibrotic stage, is really probably the stage where you've got patients that are going to be placed, or at least decided to be placed, on more long-term oxygen therapy. Now, not all ARDS survivors necessarily progress to this stage, but many do. And this stage is characterized by deterioration of normal lung architecture. So there's remodeling that occurs, and you've got the presence now, the manifestation of fibrosis. There's some patients that have minimal scarring, but others with very severe variety, requiring home oxygen for the rest of their life. The picture shown to the right, according to Dr. Yoshikawa, who published this not too long ago, is a histological image of that mid-stage, that proliferative or organizing phase of ARDS, also known as the subacute version, where you have these almost polyp-like spindle-shaped fibroblasts that infiltrate the alveoli. Of course, anytime the distance between the free surface and the diffusible layer of the alveoli is thickened, you're likely doing harm, right, to the body. You're developing this degree of refractory hypoxemia. And so this would be your free surface, where usually gas is attempting to come in contact with the alveolar capillary interface. This would be your alveolar surface, your epithelial tissue, and this would be more where your capillary bed was located. I believe he's got some shading here, or some staining. So right in this particular area is where you have the cells that begin to accumulate, and therefore oxygenation becomes even more difficult. To be clear, there's no magic potion or perfect combo of treatments for ARDS. That said, mortality rate remains extremely high, even in light of our current technologies and advancing knowledge of the syndrome. In almost any area of the country or the world, mortality rate is still very high for ARDS, regardless of just how much knowledge is known and what is being implemented. Cited here is a systematic review published in Respiratory Care Journal just a few years ago, where they categorize mortality rates according to type, such as 28 days mortality, 1 month, 60 days, 3 months, and then at 1 year. There is a reason they call all ICU patients ICU survivors, right? From the original almost 1,100 studies that were evaluated here, they reviewed 177 papers in detail. And after all of that, their conclusion was that reported mortality rates are highly variable among institutions. I mean, that's no surprise, right? And often biased. Without offering an exact number with confidence, we just simply recognize that ARDS-related mortality rates remain high. Mortality rates range from about 30% to about 45%, depending on many variables. So what we're saying is, at the very least, a patient that has a true diagnosis of ARDS has almost a 1 in 3 chance of dying. Let that sink in for a moment. That's a big deal. This was an interesting study from 2020 that specifically identified adult patients hospitalized at a single tertiary care center. So they looked at a period from 2016 to 2017. They identified those with acute hypoxic respiratory failure, and they defined it using the PF ratio of less than 300. So they met that ARDS criteria. And these were patients that had the PF ratio less than 300 while receiving invasive mechanical ventilation for at least 12 hours. So these patients all died during hospitalization, by the way. ARDS was identified and verified by multiple physicians using the Berlin definition. So just under 400 patients were studied. It wasn't a large-scale study, but very powerful. You can see that sepsis, pulmonary dysfunction, as you would assume, neurologic dysfunction, just some of the most common identified causes of death. And by the way, 70% of all those who died exhibited multi-organ failure at death. I mean, we definitely seem to have clear perspective on the effects of ARDS. So back to where we really are as a medical community. Although rarely is there even a complete consensus the world over, let's review the most updated current Berlin criteria for ARDS, and we'll quickly move into classification, and then we'll end today with some evidence-based ventilator strategies. The overarching summary is: 1, onset is quick, less than a week. Chest X-ray is going to show bilateral infiltrates. There is respiratory failure present, unexplained by cardiac failure or being fluid overloaded. In other words, pulmonary edema is present. You have a PF ratio that is decreased at least to 300 or below, and you and I normally should have a PF ratio greater than 400 for this number. And you'll notice in the oxygenation section here that all patients are assumed to be on minimum PEEP of at least 5 centimeters of water pressure. That is ARDS in a nutshell. This is the latest definition. Even though you see the reference there from 2012, it has not changed very much. Very recently, though, just a bit ago, just last year, 2023, the group published a paper in Critical Care promoting the idea that we should seek to further define or standardize an assessment of ARDS that encompasses pulmonary and extrapulmonary involvement. Well, easier said than done, right? They argue that PF ratio, also known as PaO2 to FiO2 ratio, is insufficiently sensitive to inform treatment selection. Now, I cannot disagree, can you? They do include, by the way, a really nice case study of a septic patient with a urinary tract infection that was initially placed on high-flow nasal cannula, eventually placed on invasive ventilation, but did improve and was discharged after a few days. The key point in their article, though, was, did their patient have ARDS? They contend that their patient did, in fact, meet ARDS criteria at first, but quickly fell off a short stint after on mechanical ventilation, according to the latest Berlin definition, which includes PF ratio. So what they're essentially saying is maybe we need to think about it a little differently, because suddenly when being treated, even in the early stages, many patients who have been classified with ARDS no longer have meeting that criteria. So maybe they should be removed from the list. Now, today's topic isn't intended to stir up controversy, okay? We're just going to, as always, look at the evidence. But this is what the group is suggesting. As you can see, they recommend new data sets to be used, 2010 and beyond. And they're recommending that PF ratio be calculated under more so-called standard conditions, such as calculating PF ratio at predetermined FiO2 and PEEP levels. Not bad ideas, honestly, right? But theoretical doesn't always easily translate into bedside practice, and you and I know this. Well, let's dive into it a bit. Let me reiterate, there's no magic potion or absolutely effective treatment for ARDS. We'll focus mainly on arguably one of the more important aspects of therapeutic intervention or so-called treatment, and that is mechanical ventilation. So we know that ARDS results in respiratory failure. That's fairly clear. They have complex oxygenation needs. Sometimes a less is more approach may be acceptable with respiratory failure, but what about with ARDS? Well, I hope to address this moving forward. It's obvious that multi-organ failure is an unfortunate reality in the wake of ARDS, but not always, but much of the time. So how do we avoid it? Well, for starters, we seek to judiciously ventilate the lung while seeking to protect lung tissue as much as possible in the process. Almost irrelevant when you pull an article and from what journal and what year, the fact is it's long been established that ARDS and organ failure go hand in hand and not just lung failure. This data here was regarding ARDS treatment with a PPV focus. So let's get down to it. Regarding mechanical ventilation of ARDS patients, there's been many recommendations over quite a few years, so let's focus on the evidence. There was a team from Vanderbilt that published a review in Chest just over 15 years ago, so it's been a moment, titled Mechanical Ventilation in ARDS, a State-of-the-Art Review, and it's one of the most cited articles of the time. They evaluated only high levels of evidence, so randomized controlled trials, including some of the most well-known of the day, and here's the summary. A low tidal volume strategy with maintenance of plateau pressure less than 30 centimeters of water pressure when possible is the only method of positive pressure ventilation shown to date to improve survival. They recommend as what they call useful respiratory therapies or rescue therapies, we'll call them just in general, for severe hypoxemia, things such as high PEEP, sometimes called super PEEP, alveolar recruitment maneuvers, prone positioning. You that work regularly in ICU have no doubt seen some of these techniques integrated over the years for both ARDS and non-ARDS patients alike. When attempting to manage severe hypoxemia refractory to usual care, they can still be your go-tos within reason, right? High PEEP, alveolar recruitment maneuver, prone positioning. So do these recommendations remain today? Well, let's take a look. So before we swing into more recommendations, this multi-center clinical trial that was conducted in collaboration among 4 different academic medical centers, specifically their emergency departments, is shown. Now, realizing institution-specific influence, of course, and other potentially unaccounted for confounding variables, as we call them, are always certainly at play. This group's conclusions may unfortunately align with what we all see at any given time in our emergency departments. Unfortunately, lung protective ventilation is infrequent in patients receiving mechanical ventilation in the ED, regardless of ARDS status. And we've all been a recipient of that order potentially, where it makes us cringe, right? Where we thought, you know, this is maybe too much. I mean, this study was conducted among 4 academic medical centers. Supposedly, we in academic medicine should be cutting edge and evidence-based, right? But we certainly can all relate to some degree, I'm sure. It was also emphasized that progression to ARDS is common after admission. Is it the cart before the horse? Wow. I mean, the name of this publication says it all, right? 50 years worth of research. Now, to be clear, this publication is shown focused primarily on answering the question of whether ARDS patients, particularly those with severe cases, should be allowed to spontaneously breathe while on mechanical ventilation. And this is a real buzz topic, even currently. The group present that evidence is accumulating that spontaneous breathing may actually cause or worsen lung injury overall, particularly if spontaneous breathing is vigorous. In the end, admittedly, the net impact of allowing ARDS patients to spontaneously breathe while on positive pressure ventilation really depends on the severity of the lung injury or the ARDS condition. They recommend ventilator strategies allowing spontaneous breathing as well as mechanical ventilation with muscle paralysis during ARDS. I know it's vague, right? So this graphic is directly extracted from a recent publication in Critical Care. There's the ongoing recommendation of low tidal volume strategy, as low as 4 mils per kg predicted body weight, is acceptable in certain patients. And there's also this concentration on driving pressure, also known as delta P. As well, there is well-established merit in the use of esophageal balloon pressure monitoring. However, most experts would argue that there are many barriers to acquiring accurate results and being able to properly interpret the results, even when there is fidelity of the measurement. So in 2021, an Italian group of physician researchers published what they call 10 golden rules for mechanically ventilating ARDS patients. And nothing was particularly groundbreaking. However, it does offer some great perspective, and I've summarized the gist of their so-called rules. Number one, make sure that we classify correctly. Number two, we know tidal volume is important to monitor as well as plateau pressure. And of course, driving pressure should be at the forefront. Implement and exploit PEEP. Use it for recruiting, but use it as needed. Utilize recruitment maneuvers. And in certain cases, pharmacologic paralysis may be beneficial. We're not saying to paralyze every patient. That's the 1980s that we did that, right? Decrease mechanical ventilatory support when possible. We're, again, trying to take a patient, conservatively ventilate as much as possible, remove them from that deteriorative stimulus when possible. So whatever caused them to need mechanical ventilation to start, they should be removed as soon as possible once that underlying issue resolves. Prone positioning is mentioned, and then some of those non-traditional rescue therapies. ECMO is always a possibility unless you don't have that option, and then the patient ends up transferred, right? And then wean, wean, wean. So just a side note, this is a fairly well-known, albeit short list of some of the most common mechanical ventilation-related complications encountered by ARDS patients. You'll no doubt see many of these pathologies present outside of the ARDS condition, but more commonly seen with ARDS in those patients who experience mechanical ventilation. Multi-organ failure, very common in ARDS patients. Just a friendly reminder, we're dealing with extremely delicate lung tissue by nature. But when suddenly surfactant is also deactivated by the rush of fluid into the gas exchange bases, you quickly have to be especially creative in avoiding underinflation and risking atelectasis trauma. You also have to avoid hyperinflation, risking volume trauma. So it's the avoidance of that cyclic closing and opening that we are targeting. Studies suggest that both repeated cyclic closing and opening of lung units, as well as excessive driving pressure, is what really adds to the already excessive pulmonary and systemic inflammation. By the way, to the left here, you're looking at a version of an alveolar duct into a cluster of alveoli, and to the right, upper, you're seeing hyperinflated lung tissue under electron microscopy. Bottom right would be slightly underinflated. So let's get to how do we ventilate fluid-filled, stiff lungs? What's the takeaway? What can we do on mechanical ventilation, considering there are a multiplicity of modes, fine-tune what we call boutique settings that we don't always have orders for, or maybe there are just proprietary options available to some, not available to others. There are some practices more open-minded than others, more evidence-based ordering providers compared to others. So I'm a respiratory therapist, and I understand the barriers, but they're comes times when the patient is difficult to oxygenate and traditional options are exhausted. And there's just that moment where those caregivers or ordering providers are less prone to be open to trying something, but they might suddenly be very open to trying whatever may work. It just depends on the moment. So I want to leave you with some items of consideration, all evidence-based, of course. This picture definitely oversimplifies the idea of ventilating many alveoli that have various filling pressures and opening times, all adjoined to come in contact with one another between the pores of cone and alveolar ducts, but we can get the gist here. There's only three main variables that exist on mechanical ventilation plotted over time, of which we can manipulate in real time, and that's flow, pressure, and volume. A ventilator is a pressurized flow generator. Oversimplified, it's not dissimilar to pouring water into a bag. It's all fluid dynamics at its core. The problem lies when the bag is not distensible and it takes more time to fill. You can do damage if the process is rushed. So just a bit of tongue-in-cheek here, just like an auscultation, the process of positive pressure ventilation is almost identical to the original way. Only the method has really changed, only the technology, right? So what you're seeing here is the first stethoscope that was invented by woman, by healthcare in general, where you just put your ear to the patient. The actual first stethoscope was invented in 1816 by French physician René Laennec. With mechanical ventilation, we're still taking compressed gas. We're forcing flow under high velocity into a very delicate system. The process really isn't that different than decades ago, but the methodology should be. So just like an auscultation, the process of positive pressure ventilation is almost identical to the original way. Again, only the method has really changed. So there's the first stethoscope, formerly to the left, and the modern day version to the right. So let's look, we're not going to do too much math, no worries, but let's look at Newton's equation of motion. Acceleration is the derivative of the velocity, and velocity is the derivative of position. In positive pressure ventilation, we must overcome both the elastic and resistive forces of the lungs. The lung resists stretching, particularly during times when the diaphragm is not contracting and we are controlling each breath. Good old Poiseuille's law shown there. Don't worry, we're not going to work it out, but think about, according to the infamous Poiseuille's law, flow is indirectly proportional to the length of the tube and viscosity of the gas. More importantly, flow is a function of the fourth power of the radius, also known as if pressure remains constant and you decrease the radius of a tube by 1/2, it reduces the gas flow to 1/16 of its original flow rate. To put it into perspective, similarly, if you just decrease the tube's radius by 16%, gas flow is cut in half. Think about bronchoconstriction, mucosal edema, even condensate in a smaller tube can make a world of difference. But what's listed here, we're overcoming the resistance in the airways, the ability to stretch of the lung tissue, the elastic recoil, and not counting the thoracic cage, which may be quite rigid and stiff in elderly patients or those that have a turtle shell on in the ICU, or maybe they're in the burn unit, have their thoracic cavity wrapped. Those are all considerations. So think about a time constant as the time necessary to fill a particular lung region to a certain portion of its potential filling capacity. We're trying to target 3 to 5 time constants for complete filling. So in other words, in general, within a normal lung, surface tension is not constant due to a mixture of the phospholipids and proteins floating atop the alveolar epithelium. That's what surfactant is. Well, gas tends to flow from larger to smaller alveoli, producing this homogeneity of alveolar volume and stabilizing the lung units. However, with ARDS, surfactant is actually deactivated by the mass infiltration of lung fluid. As a reminder, in the presence of constant flow, the low compliance lung units will have a short time constant. High resistance units will have a high time constants. So if you have high airways resistance, you need a longer I time under most cases if you're trying to prevent back pressure. With ARDS, it's more of a compliance issue. In other words, low compliance units have a short time constant. They fill very quickly, but they may not fill adequately. Theoretically, if you allow enough time, even the most non-compliant lung can accept volume within reason. If we give enough time, we can pack it in. But how we pack it in is the question of safety. So this is a question no doubt constantly debated the world over. So let's look at some data. At face value, you could argue either if you truly know how to manipulate the ventilator. However, most clinicians assume pressure-targeted modes are more lung protective. But let's see what the data tells us. So this was a systematic review and a meta-analysis to determine whether pressure-controlled CMV or pressure-controlled inverse ratio ventilation has demonstrated advantages over volume-controlled CMV. And the Cochrane tool for risk of bias was used for methodologic quality. That's pretty common when you do a systematic review. We also, they claimed as a study, they had this physiologic criteria as quality indicators for selecting the studies. The outcomes included compliance and gas exchange. And you can see their results here, their conclusions rather. And what they found is clinical available data do not suggest any difference in the outcomes between pressure-controlled and volume-controlled ventilation in acute respiratory failure. Let's break it down to more specific with ARDS. So this was another systematic review evaluating specific acute lung injury and ARDS. Now notice the date 2015. This group, though, pulled over 60 years worth of studies from 1950 to 2014. You can see from the highlighted conclusions here what they found. They're saying that currently available data from randomized control trials even are insufficient to confirm or refute whether pressure-controlled or volume-controlled ventilation offers any advantage for people with acute respiratory failure due to acute lung injury or ARDS. So I know you on the call probably have strong opinions one way or the other, and we're seeing a little bit more pressure control used, I think, in the market. But what does the research tell us? There's really not a dramatic difference, at least in outcomes. Excuse me. So in 2000, backing up just a bit, the famous ARDSNet study, a landmark randomized control trial, demonstrated an approximate 9% absolute mortality reduction when using a strategy of low tidal volumes. And by low, they meant 6 mils per kg predicted body weight with a limitation of plateau pressure of 30. That's why we have those numbers still around today. However, to date, current research may point more towards alerting to driving pressure, as shown here on the screen. Lung protective strategies, higher PEEP, as indicated, lower tidal volumes, mitigating driving pressure, and that cyclic opening and closing, trying to avoid that process as much as possible. I just wanted to include this snippet here. Here's an article related to the well-cited FROG study, standing for French and European Outcome Registry. They evaluated 1,570 patients after being discharged from the ICU. So these were ICU survivors. And yes, the ICU is a dangerous environment for the patient. We assume an ICU patient is sicker than average, or they wouldn't be there. So yes, they're already at high risk for mortality just upon admit. However, what they establish is that ICU survivors have decreased long-term survival compared to the general population. This means they die an earlier death even after surviving an ICU stay. Pretty remarkable. Just some thought, maybe they should have consulted pulmonary critical care or the respiratory therapist before placing this poor patient on mechanical ventilation, but they did not, and you can see the result here. For you that are more diagnostically inclined, we have a very beautiful tension pneumothorax here. There is the outlining of the visceral pleura, and all this is free air. You never want to see that, right? It's called the ventilator mismanagement sign. So where's the so-called sweet spot? Just an electron microscopic view of alveoli from hyperinflation represented at the top left. to atelectasis represented at the bottom right. You can visually appreciate here the dramatic difference between the varieties of expansion level. Also consider there are very delicate compressible, contractible, and recruitable capillaries just adjacent to these gas exchange units. So pulmonary blood flow is certainly being affected in real time as the alveoli expand and contract. Again, the question is, where is the sweet spot of ideal inflation? Well, conceptually, we've known this concept for many years. There is a sweet spot of ventilation where we avoid lung collapse at end expiration, but at the same time prevent overfilling, overdistension of the lung during inspiration. But how do we assure this so-called safe window in the middle here? Well, for starters, conservative tidal volumes, 4 to 7 mils per kg, monitor ventilating pressures, whether in volume targeting mode or pressure targeting mode, evaluate all available scalars. It's very important, as you know, to be dialed in to your ventilator graphics. Many ventilators now allow you to quickly evaluate a flow volume loop and other compliance curves without any adjustment or patient stimulation at all. You just have to pull it up on the screen. We know, however, it's not always as straightforward with ARDS. So how do you set best PEEP? Well, technically, to even get a curve similar to what you see here, there has to be no spontaneous efforts, and you need controlled flow delivery, typically only achieved in volume targeted mode. The concept, however, is the most important here. If we can identify the point, the pressure level at which the lung begins to rapidly fill with volume, and arguably the most important, the level at which the lung begins to collapse on expiration, the goal is just to set PEEP just above that level to prevent lung collapse on expiration. Again, we want to avoid cyclic closing and reopening breath by breath to prevent ventilator-induced lung injury. Their lungs are already injured if they have ARDS. We should not add to their pulmonary inflammation if it can be prevented. Now, really, we should be most concerned with stress and strain. Just generally speaking here, yes, plateau pressure, and yes, tidal volume to ideal body ratio is very important. Some of those well-known names in clinical research are referenced here. Let's look at this short list. So yes, lower tidal volumes are better, and yes, we should maintain the lowest pressures possible, but even then the lung experiences significant stress and strain. Sustained inflation, think super PEEP, is better than cyclic closing and reopening. The absolute most gentle delivery possible as the patient can tolerate is ideal. Easier said than done many times, I realize. And much has been published as of late related to whether to allow spontaneous breathing during the more severe stages of ARDS. The consensus seems to be moving more toward lung protection being more important than keeping the diaphragm even in play, or at least for the short term while the ARDS condition is the most severe. So just some key points to leave you with today. Number one, lung protection is a must. The application of optimal PEEP may require a little higher than traditional settings. You may have to enter into that double-digit realm, and it's okay on occasion. We want to target as low plateau pressure as possible. This is the pressure the lung actually experiences, not related to airways resistance or dynamic flow. And then recruitment maneuvers, as mentioned earlier, use with caution, but still use them on occasion. Don't forget about good old-fashioned prone positioning. And recently we had a patient where nothing else was working, and we decided let's try prone positioning, and immediately their oxygenation was enhanced significantly with no other intervention. Ventilator synchrony is sometimes harder to achieve with ARDS patients, but the goal is not to create a environment where their oxygen levels are being drained from effort during mechanical ventilation. And remember, driving pressure is defined as the ratio between tidal volume and pulmonary compliance. And it can be estimated by calculating just the difference between plateau pressure and PEEP. And you've got some non-traditional intervention options as well. You may or may not have available at your institution, but just a consideration. Thank you so much for your time, and I will take any questions that you might have.